Hello everybody, in this video we will talk about everything that you need to know about esophageal cancer. First of all, we will explain esophageal cancer, then we will talk about 294 file questions with explanations and roll to Emree question with explanations. First, let's explain esophageal cancer. We have two main types of esophageal cancer. The first is adenocarcinoma, which is the most common type of esophageal cancer in the United States, and the second is squamous cell carcinoma, which is the most common type of esophageal cancer worldwide. If you come to the localization, squamous cell carcinoma of the esophagus tends to occur in the upper and middle third of the esophagus, whereas adenocarcinoma occur in the lower third of the esophagus. This is very important to know about the localization of esophageal cancer. So keep in mind localization for the exam. Next, let's talk about the causes of adenocarcinoma. The most common cause of adenocarcinoma is smoking. Next, we have obesity, male sex, older age, especially from 50 to 60-year-old, gastroesophageal reflux disease, and Barrett's esophagus. Squamous cell carcinoma causes. The most common cause of squamous cell carcinoma is alcohol consumption, smoking, diet low in fruits and vegetables, nitrosamine exposure, human papillomavirus, radiotherapy, beryl areca nut chewing. These two kind of nut chewing can lead to squamous cell carcinoma. Next, we have the esophageal candidiasis, which is fungal infections. This can lead to squamous cell carcinoma of the esophagus. Same like adenocarcinoma, this male sex is compared to female is more affected by squamous cell carcinoma. Older age, and the adenocarcinoma, the age was from 50 to 60, but here age is from 60 to 70 years old patients. Next, we have a syndrome which is called Plummer-Vinson syndrome, can also lead to the esophageal cancer, the squamous cell carcinoma of the esophagus. In Plummer-Vinson syndrome, we have three things. I will a little bit explain Plummer-Vinson syndrome. Number one, dysphagia. Number two, IDA, iron deficiency anemia. And number three, we have upper esophageal webs. Next, we have achalasia. The last one is diverticola of the esophagus, especially Zinker diverticulum of the esophagus, which is very important. Let's talk about a little bit the classification of esophageal cancer, which is called severe classifications. Before to talk about the types of severe classification of esophageal cancer, first of all, we should know about the Z-line, because this classification is on the base of Z-line. The physiological transformation zone between squamous and columnar epithelium in the esophagus is called Z-line. So, the type 1 severe one is the center of the tumor located 1 to 5 centimeter above the Z-line. This is called type 1, and this is associated with the Barrett's esophagus. Surgical approach of type 1 include transthoracic esophagectomy, partial gastrectomy, lumpectomy. Let's talk about type 2. Severe type 2, the center of the tumor located from 1 centimeter above to 2 centimeter below the Z-line. And type 3, center of the tumor located 2 to 5 centimeter below the Z-line, which is also called subcardial gastric cancer. The type 2 and type 3 type of esophageal cancer surgical approach is same, and this include transhiatal esophagectomy, total gastrectomy, extended lumpectomy. This was all about the classification of esophageal cancer. Let's talk about the clinical feature, which is very important of the esophageal cancer. Esophageal cancer, often asymptomatic, may manifest with dysphagia and retrosternal discomfort or retrosternal chest pain. General sign of the esophageal cancer, which is include weight loss, dyspepsia, sign of anemia, sign of advanced disease. This is very important to learn for the exam. It's very crucial. Progressive structural dysphagia from solid to liquid. The patient in the start will have dysphagia with the solid and then will have with the liquid with possible odonophagia. The next sign of advanced disease is retrosternal chest pain or back pain. This is very important. Next, there is cervical adenopathy, which is very important, and most of the past paper they ask about the metastasis of the cancer, the metastasis sign of the cancer. So if you find in a patient cervical adenopathy, it's highly suggestive of metastasis. Next, if you find in a patient hoarseness of voice or persistent cough, it means the cancer infiltrated to the recurrent laryngeal nerve, and this is very important for prognosis. The last one we have is Horner syndrome. I will talk a little bit about the Horner syndrome. In Horner syndrome, we have three things: meiosis, number 2 ptosis, number 3 facial anhydrosis. The last part of the clinical feature of esophageal cancer is upper gastrointestinal bleeding. So in this way, there will be present in the patient's hematemesis or melana. Let's talk about the crucial part of the esophageal cancer, which is diagnosis. How we can establish the diagnosis of esophageal cancer. The best initial and most accurate test for esophageal cancer is EGD plus biopsy, which is required to establish diagnosis. For the diagnosis, we need biopsy and EGD. Next, for the staging of the tumor, we need CT scan and endoscopic ultrasound. Let's talk about the treatment. Best initial treatment of the esophageal cancer is chemoradiations and surgical resection of the esophageal cancer. And surgical resections, endoscopic submucosal resections for mucosal lesion, and subtotal or total esophagectomy, which is indicated in localized or resectable locally advanced disease. We have two options here. Two options include in the subtotal and total esophagectomy, gastric pull-through procedure, or colonic interpositions. Next, let's talk about the prognosis of esophageal cancer. The prognosis of esophageal cancer is the estimated survival of a patient diagnosed with esophageal cancer between 2012 to 2018. So localized cancer, which is not spread to the surrounding organ, this has 46% 5-year relative survival rate. And regional, which is spread to surround regional lymph node, this have 26%, and distant, which is spread to the distant organ, this have 6%, and combined any stage have 21% prognosis, 5-year survival rate. Let's talk about the very crucial part of this lecture, which is the 294 files, questions, and explanations. Okay, the first question is: an old man present with progressive dysphagia from solid to liquid, but can still take some fluid. He also has hoarseness of voice. Most likely, what's the most likely diagnosis? So most likely diagnosis in the option there will be squamous cell carcinoma or adenocarcinoma. So the hoarseness of voice is one of the symptoms of the esophageal cancer. So in the option there will be squamous cell or adenocarcinoma. The next is a patient has cancer of the mid 1/3 of the esophagus. He has no history of smoking. What is the diagnosis? So in these three options, the mid-third, okay, before in the start I talk about the localizations of esophageal cancer. Squamous cell carcinoma tend to occur in the upper and middle third of the cancer, and whereas adenocarcinoma occur in the lower third. So this is very crucial for the exam. So this question is asking about the localization of the cancer. So squamous cell carcinoma, the right answer is number B, which is squamous cell carcinoma. A 6-year-old man was diagnosed with cancer in the middle third of the esophagus. So if you see in the questions, middle third, mid third of the esophagus or upper third of the 1/3 of the esophagus, you should think about the squamous cell carcinoma. So what sign make the patient most likely untreatable? Here they asking about the metastasis of cancer. Okay, when the cancer is metastasized to surrounding organ, then this is the untreatable condition of the patient. So here we're talking about the two things there in the clinical feature of adenocarcinoma. The number one is cervical adenopathy, and number two we talk about the hoarseness of voice, and also we talk about the persistent cough. This can this is the spread. This show the spread of the cancer to the surrounding organ. So here the right answer is B. Question number 5. A 60-year-old man was diagnosed with the cancer of mid of 1/3 of the esophagus. Mid 1/3 of the esophagus. Before I tell you if there is mentioned mid or upper, so you should directly think about the squamous cell carcinoma. What makes his esophageal cancer untreatable? So here is the main question is untreatable, which means the cancer should be metastasis. So what is the metastasis of the cancer? So here is the hoarseness of voice before we talk about in the clinical feature. So recurrent laryngeal nerve involvement, when the cancer is spread to recurrent laryngeal nerve, the patient will have hoarseness of voice. So this is the untreatable question's answer. Number A is the correct answer. A patient has esophageal cancer. What makes the diagnosis of cancer untreatable? The same questions. This last three is the same questions. So again, number A, inability to speak full sentences. So recurrent laryngeal nerve involvement can lead to hoarseness of voice or inability to speak full sentences. This was all about the esophageal cancer.